Hello and welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Zachary Schwartz. This podcast is the first in a series of 3 episodes on bloodstream infections, recorded from a live symposium. In this episode, we hear from Dr. Jasmine Marcelin from University of Nebraska Medical Center in Nebraska. She'll discuss how inadequate antibiotic coverage can be linked to increased mortality and length of stay. To view other episodes, or to follow along with the slides, visit the show notes for this episode. Now let's get started with Dr. Marcelin.
I will start with a section on the ongoing challenge of antimicrobial selection for bloodstream infections. Just a bit of background where I'm coming from with this presentation. I'm a clinician. I spend the majority of my time on either a teaching clinical service with residents, fellows, students, or a non-teaching clinical service with PPs. And so most of it is spent in, clinical decision-making and patient care. And so I'm going to be presenting to you just like what it is that we're doing on a daily basis when we're seeing these patients. We'll start off with a case. This is a 52-year-old patient who has well-controlled diabetes. The patient was admitted to a rural safety net hospital with fever, dysuria, and flank pain. The initial urinalysis that was obtained showed 3+ leukocyte esterase, 2+ bacteria, WBCs. Seems like the person has a urinary tract infection. They also obtained procalcitonin, pretty high, 6.2, peripheral white blood cell count, 18.5. The patient was empirically started on ceftriaxone 2 grams daily. Then a CT scan of the abdomen and pelvis done in the emergency room showed pyelonephritis. They obtained blood and urine cultures, which showed on gram stain, gram-negative rods. The ceftriaxone was continued while the cultures were pending. So that's the case that we're framing things for. And so thinking about sepsis, September was Sepsis Awareness Month. It's something that is on many of our minds. There are about 48.9 million cases of sepsis that have been identified worldwide, with 11 million deaths that were reported. 19.7% of deaths worldwide are due to sepsis. It is a really important problem for us as infectious diseases clinicians. Even if you're not an infectious disease clinician, you're taking care of folks as a hospitalist or other specialists. These are things that we need to deal with all the time. And the incidence of sepsis kind of varies worldwide depending on the geographic location, with higher incidences that we can see in South America and Sub-Saharan Africa, as well as in some of the Asian countries. So the burden of bloodstream infections and mortality globally has been also documented. So the global estimated burden of bloodstream infections, this was in 2019, was about 119.2 million disability-adjusted life years, accounting for about 2.9 deaths. And 51% of the bloodstream infections and deaths from bloodstream infections are from gram-negative bacteria. And so gram-negative bacteremia is a problem that we really need to be thinking about as we're considering the impact of sepsis on our patients. There was one study that was done in Ontario in 2017 that looked at the burden of bloodstream infections that found that the incidence was about 150 per 100,000 population. The most commonly identified organisms were E. coli, with about 40 per 100,000 population, and then Staph aureus with 22 per 100,000 population. And the mortality risk does vary by the organism, with Staph aureus having higher adjusted odds of mortality than E. coli. This is something that we have experienced clinically, but gram-negative bacteremia is still a really big problem. And so this slide kind of shows the burden of bloodstream infections and mortality by organism. And you can see that the Staph aureus and the E. coli are the ones that have the largest mortality as well as the highest number of episodes. And so even though E. coli is bacteremia more common than Staph aureus, the mortality is slightly higher with Staph aureus. But you can also see on the left-hand side where some of the other organisms that we do concern ourselves with will be falling. And when we think about the burden of antimicrobial resistance, sepsis, and why we do what we do in terms of antibiotic stewardship, one of the things that come to play is Clostridioides difficile. And C. diff is an issue that causes the bacteremia from C. diff, less common, but the morbidity and mortality from C. diff is a problem that we do need to be concerned with. So speaking of antimicrobial resistance, we have ongoing threat globally, with about 1.14 million global deaths attributable to bacterial antimicrobial resistance. And this is expected to increase as we use more antibiotics, as we lose more antibiotics. And the threat is partially driven by this overconsumption and inappropriate use of antibiotics. So we're talking about how can we use our antibiotics better. Couple of the organisms that are really important in our overall view of antimicrobial resistance, thinking about Enterobacterales that are multi-drug resistant, as well as Pseudomonas. You'll see that the CDC has identified several types of organisms as urgent threats as well as serious threats. And thinking back to our case that we started off with, this patient had an E. coli bacteremia. And when we look at the threat levels of serious hospital onset ESBL producing Enterobacterales are really an important thing for us to be considering. Just wanted to give you a slide on the US and global disparities in sepsis, bloodstream infections, and antimicrobial resistance. So it's important for us to understand that while these issues are important to us in general, sometimes they do not affect populations in the same way. And understanding disproportionate impacts of sepsis, bloodstream infections, and antimicrobial resistance can help us as we're thinking about how can we be intentional when we're developing our antimicrobial stewardship initiatives or assessing what the potential risks are so that we can help our patients to be safe. And so the data that you see on the screen, which you'll be able to take a look at afterwards, looks at, from a bloodstream infection, for example, disproportionately higher rates in people who are experiencing poverty, household crowding, and lower education rates. And there's also global disparities with increased rates seen in Western and Sub-Saharan African countries. From a sepsis standpoint, we have data in the United States that shows that Black, Native American, and Hispanic people have higher sepsis mortality than compared with their white counterparts. And some of that may be related to the, delay in diagnosis, delay of recognition of the signs and symptoms of sepsis, and opportunities for us as healthcare professionals to educate the different communities on what the signs and symptoms are of sepsis so that they can recognize it earlier and maybe bring these rates down. And then from an antimicrobial resistance standpoint, we have data that suggests that groups from minoritized, racial and ethnic minoritized groups may have higher risk for infections with pathogens that have increasing antimicrobial resistance. And that includes, bacterial and fungal organisms. So when we think about the drivers of antimicrobial resistance, inappropriate prescribing is one of them. And that also translates to where there are inequities in inappropriate prescribing. And so this slide has a few of the data that has been collected looking at where some of this inappropriate prescribing occurs. So we can see differences in antibiotic prescribing based on the patient, race and ethnicity, geography, and socioeconomic status. There's also data that shows that the clinician who is doing the prescribing, the prescriber, whether or not their age is greater or less than 30, or if they are a physician versus an APP, or how much years of experience that the prescriber has can also play a role in how people prescribe. We see that there are data that suggests that people who are not white are less likely to receive empiric antibiotic broad spectrum therapy than patients who are white. And this is a trend that is seen in the West and South Central regions of the United States. There's insurance disparities as well, where folks who have private insurance are more likely to receive antibiotics inappropriately and overall compared with folks who have public insurance or uninsured. So all of this is meant for us to understand that prescribing differences occur. And it's in the context of why do we need to prescribe antibiotics appropriately? We all know this. If we are not giving a patient appropriate antibiotic coverage, we have increased mortality, length of stay into the hospital. Hospitalizations are more costly. If we give them broad spectrum antibiotics unnecessarily, we increase the risk of C. diff, we increase the risk of AMR, adverse events, and mortality. And so it really requires us to be more judicious with how we prescribe our antibiotics. But there are difficulties with optimizing antibiotic use. Some of this is the diagnostic uncertainty. As a clinician, oftentimes we get called because the patient comes in with symptoms, but we're not 100% sure what exactly is it. Is it sepsis? Is it not? Is it bacterial? Is it not? What is causing it? We don't know the answer to that yet. And so therefore, the need to know the organism that's causing the bloodstream infection really can help us to reduce that diagnostic uncertainty and guide appropriate antibiotic choices. We have our traditional culture methods that require 24 to 48 hours, and that delay is causing us to potentially be more broad in our initial antibiotic selection. And we have the issue about antimicrobial resistance, where we don't necessarily have the data that we need to know which antibiotic to choose up front. And perhaps if we choose wrong, if we guess wrong, we could be contributing to AMR in our population. If we guess wrong, we could also contribute to undertreatment of our patient. And that's really, as clinicians, something that we wrestle with. And so that's that balance between prioritizing patient safety and stewardship. So the key takeaways from this, from me as a clinician thinking about selecting antimicrobials appropriately for bloodstream infections, is that sepsis and bloodstream infections are common. We see them all the time. They cause millions of deaths every year and are very costly. There are disproportionate burdens in low-income, middle-income countries. There are disproportionate burdens in rural versus urban settings and in different demographics. And we also see inequities in prescribing. And so there's a lot of work for us to do in trying to ensure that we're doing this appropriately. We know that there's inadequate antibiotic coverage can be linked to increased mortality and length of stay, but unless it's unnecessarily broad antibiotics can cause adverse effects. And it comes down to how can we optimize the selection of our antibiotics and reduce our commission bias of choosing things more broadly because we don't have all the information. So in this particular patient, what happened was that patient was diagnosed with pyelonephritis, as we saw. The gram-negative bacteremia was initially treated with a ceftriaxone. By day 2, still wasn't improving. By day 3, it grew the E. coli. Stewardship or the susceptibility testing was in progress. Ceftriaxone was continued. By day 4, fever was continuing. Patient was not improving. CT scan revealed a developing renal abscess. And then finally, we got the susceptibilities back, showing that the organism was resistant to ceftriaxone. At that point, ceftriaxone was changed to ertapenem. So now day 4, day 5, and next couple of days, patient became more stable, ready for discharge, and then sent home on oral levofloxacin. But there are ways that rapid AST could have helped in this case. So first, the resistance to ceftriaxone could have been identified within hours instead of several days, and then we could have had an earlier switch to more effective therapy. That may have prevented the development of this renal abscess. Hard to know, but we do know that this patient had a prolonged fever and bacteremia sepsis symptoms while they were on inappropriate treatment. They could have recovered a lot faster if we had switched them over to the appropriate treatment sooner and have been discharged from the hospital, therefore got a less of a hospital bill, or at least less costs to the hospital itself. And so there's a lot of opportunities for implementing rapid AST to help out with our clinical decision making. With that, I'm going to pause for 3 minutes of questions and answers. Remember to use your iPads for your questions. If you would like to hold your question to the end with the panel, that's all right as well. But we'll have an opportunity for those who are online and in the room to be able to field any questions that might come in right now. Thank you.
So while we're waiting for some questions to come in, I have one for you. Thanks for the really informative talk. So I know you were talking about geographic location and race as maybe predictors associated with inappropriate antimicrobial therapy. And I've seen you talk on this topic elsewhere, but I wondered what your thoughts were for social determinants of health and how those also kind of intersect with the global problem of inappropriate antibiotic use.
Yeah, so just a clarification, it's not that it's a risk factor. It is that there are differences in the prevalence of AMR, of sepsis and other complications in certain groups. And so the social and structural determinants of health play a huge role in that. And so if you think about what social determinants of health are, these are the things that are the environments in which people live, work, play, and they affect all of the ability of the individuals to be able to have good health. And so, for example, if we have a group of individuals who are living in a rural area who have less access to healthcare that is reliable, the nearest healthcare facility is, 4 or 5 hours away. And they also have less access to pharmacy because they're living in a pharmacy desert. And they also are employed in an occupation that puts them at increased risk of exposure to antibiotic resistant organisms, for example, farming. Then when that person has an injury or develops an illness, the likelihood of that infection being antimicrobial resistant infection is higher just because of their risk of being in that environment where they are living and working and playing. And the fact that they are 4 or 5 hours away from the nearest hospital makes it so that their risk of sepsis is higher because they have to wait that much longer to get to a place. And maybe they might make a decision because it is a bit of an effort to get to that hospital to maybe minimize the symptoms or say, I'm sure I'll get over it pretty soon. Or maybe they just don't recognize it. And until that person is very ill and EMS needs to be called at that time, once they get to the hospital, remember it's 5 hours away, or maybe they have to be life flighted somewhere. They are coming into the hospital critically ill in the ICU. And so those are the ways that the social determinants of health intersect. And things like race and ethnicity are parts of the overall social determinants because of how structural racism and redlining and other policies have made it so that people are living in those areas that are increasing their risk of exposure, et cetera. Thanks for that question.
Well, thank you to our faculty, and many thanks to you, our listeners. To listen to the other 2 parts of this podcast, or to download the accompanying slides, click on the link in the show notes. Thanks so much, and we'll see you on the next podcast soon.